Hello, today with this FERNE presentation we will be discussing the care of emergency department patients with dizziness and vertigo in an attempt to appropriately diagnose and treat patients with a potential serious central etiology. My name is Edward Sloan. I'm an emergency physician in Chicago. I work with FERNE, the Foundation for Education and Research in Neurological Emergencies, FERNE.org. I have no financial conflicts. I'm the FERNE President and Board Chair. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago, here in Chicago, Illinois, where I was for 25 years. I'm currently Medical Director of the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. And I'm Medical Director for New Rose Healthcare Management. We are staffing or attempting to fully staff our safety net hospital on the south side of Chicago, Roseland Community Hospital here in Chicago. I originally presented this information at the Emergencies in Medicine Conference on March 1st, and I want to thank all the people in the Emergencies in Medicine group and all of you for participating. Our educational objectives. What we want to do is to have a better understanding of the definitions that guide our treatment of patients with dizziness and vertigo. We want to understand what are the diagnoses that are relevant as we consider the symptoms our patients present with. And most importantly, we want to know if we can determine what diagnostically will lead us to consider central diagnoses in patients, especially on the physical exam. So we want to specify the exact history and physical exam findings that we will pay attention to. And we will talk about tests such as ATTEST, HINTS Plus. We will review some relevant publications that help guide our physical exam in this process, and we will consider a few new technologies that may add diagnostic value going forward. So let's consider dizziness and vertigo dictionary definitions. It's worthwhile to go to the dictionary so we can all have a common understanding of what lay people may consider to be dizziness and vertigo. So dizziness is an adjective. It is thought to be a whirling sensation, but also it is defined as mentally confused, which is altered mental status, which clearly is different than dizziness. Vertigo, a noun, has the same information, whirl dizzily, and it also includes confused. So not only is there overlap between dizziness and vertigo, but there's also some misinformation in the Common Merriam-Webster Dictionary. So vertigo is found to include vertiginous movement, and we'll talk about that because movement is important. So what are the consensus definitions by experts who attempt to better understand the treatment of patients who present with dizziness and vertigo? We go to a publication by Jonathan Edlow and David Newman Tokar, and these two individuals have spent a great deal of time better understanding how the emergency physician or emergency provider can address adequately symptoms in patients who present with dizziness and vertigo. And in this publication, they give us what are consensus definitions developed by experts in the field. So we're going to start with pre-syncope or near syncope, which is faintness or the impending loss of consciousness. That is different than syncope, which is the transient loss of consciousness due to some amount of global cerebral hyperperfusion. It's relatively rapid in onset, of short duration, and it provides for a spontaneous complete recovery. It's often associated with loss of postural control. Patients need to be seated or they may actually fall down. So this is different than unsteadiness. Unsteadiness is the inability to stand or walk appropriately. The patient is unstable, and they often can experience this either while seated, standing, or walking. And the importance of determining unsteadiness is that if a patient walks down a hallway and literally is bouncing off the wall because they can't walk straight, this could be or represent cerebral ischemia. This is different than something they define as directional pulsion, which is also unstable, the tendency to veer or fall in a particular direction. And in other words, it means you appear to be unsteady in one direction. So directional pulsion is similar to unsteadiness in that it may suggest cerebral ischemia. I was once skiing in a whiteout with my daughter. We were on the top of the mountain at Snowbird, and when we stopped, our eyes continued to move because we could not focus on anything, because literally we were in a cloud, and that feeling of veering to the side because your eyes are not correct or because there's some inability to register the environment around you is an important clinical sign. So now let's consider, what is vertigo? How is it defined by the consensus group? Vertigo is the sensation of self-motion. So clearly vertigo, as opposed to dizziness, involves some sense of motion. That can be of the head or body when there's no real movement occurring. In other words, a slight movement of the head can cause the sensation that the body or head continues to move. So vertigo involves some sense of motion. This motion can be a sense of rotation, such as spinning or rocking, linear motion, falling downward, such as in an elevator, or some static tilt relative to gravity where the patient feels like they're moving and not standing up straight. So this movement can be rotational, linear, or have some tilt component to it. So that leaves us with dizziness. How is dizziness defined by the consensus group? Dizziness is the sensation of a disturbed or impaired spatial orientation. In other words, the patient looks out and they feel as though the environment around them doesn't seem right, that it seems to be abnormal. This is a false or distorted sense of motion, perhaps, but in general, most dizziness doesn't necessarily involve a sense of motion or vertigo. So now that we know what are the consensus definitions of important clinical terms, now let's consider the clinical history in patients who might present with dizziness or vertigo. The first thing we should consider is syncope or near syncope. Why? If a patient felt faint or they actually had a syncopal episode, that really is the first diagnosis that can and should be made. In other words, did they almost pass out like when you see blood, or did they actually pass out? If there's no syncope or near syncope, if you can determine unsteadiness or directional pulsion, walking down the hallway bumping into one wall because you can't walk straight, that really is a sign that there could be some cerebellar or cerebral ischemia and causing this unsteady gait or cerebellar ataxia. Then go on to asking questions about vertigo. Did the patient feel as though they were moving even though they were still? Did they feel a spinning, rocking, or tilting motion? Or did they feel as though they were falling downward as in an elevator? Did it occur with movement of the head? Did it occur at rest without any motion? Have they had this episode before? And are they having these vertigo symptoms now? This relates to the concept of acute vestibular syndrome, and we'll be talking about that. Last, you can ask, was there some sensation of disturbed or impaired spatial orientation? In other words, when looking about, did they feel as though there was something not right in the world around them? Or did they feel giddy, lightheaded, or some symptom that they would describe as dizziness? Lastly, you could go to the past history and ask whether or not the patient has ever been diagnosed with syncope, near syncope, vertigo, or dizziness in the past. And then you can ask questions that would relate to systemic causes of dizziness. You can ask whether the patient's ever been treated for a low blood count, low blood pressure, low heart rate, low blood sugar, or any cardiac dysrhythmias. So our take-home points from the clinical history portion of this examination of the dizzy and vertiginous patient, we consider the order in which we ask the questions. And I would suggest you go in reverse order and talk about dizziness last. First, talk about syncope or near syncope. Then talk about unsteadiness with standing or gait. Then probe vertigo symptoms, the type of vertigo, the timing, and the triggers. And then discuss feeling dizzy last. And once you get to that point, you can then review systemic causes of dizziness or weakness, such as a low hemoglobin, low glucose, low blood pressure, etc. So our diagnoses, what should we consider when we talk about our clinical history? I believe the systemic diagnoses can be determined relatively efficiently, either with the history or a brief directed laboratory evaluation, including an EKG. Syncope or near syncope can be determined based on the history. Unsteadiness with standing or gait, which suggests possible cerebellar ischemia, can be determined both on the history and a brief exam. And then vertigo symptoms, whether it's current or continuous, this would suggest acute vestibular syndrome. If it's spontaneous and episodic, that would be spontaneous episodic vertigo syndrome. And last is the episodic vertigo triggered, and we'll talk more about these three diagnoses in a moment. Lastly, nonspecific dizziness is a diagnosis of exclusion after you've considered all of these other diagnoses. So what are the relevant disease states that can cause dizziness and or vertigo in patients? This is a list in alphabetical order of diagnoses that could be related to dizziness or vertigo. The first, alternobaric vertigo, involves changing pressure, involving, for example, a ruptured TM. When scuba diving, this will cause the patient to have a dizziness symptom. But there are other diagnoses listed here. Some are benign and or peripheral, some are central. On the second page, we go all the way through Wallenberg syndrome, which is a neurological condition that is also referred to as lateral medullary syndrome or posterior inferior cerebellar artery syndrome, which is a significant central etiology for dizziness and vertigo. So let's go back and consider the three vertigo types that may be encountered in patients with dizziness and vertigo. In this table, you consider what are the potential types of vertigo and what are the potential diagnoses related to that. I refer to the emergency medicine practice monograph developed by EB Medicine, written by Jonathan Edlow, and this is a peer-reviewed document. It's called The Timing and Triggers Approach to the Patient with Acute Dizziness. This is a good monograph, and in Table 1, you see there are 3 rows that correspond to the 3 types of vertigo we might encounter. And so for each of these 3, there are benign diagnoses in yellow on these slides, and then there are more serious diagnoses in red that correspond to these 3 types of vertigo. And we'll talk about these specifically in a moment. So the diagnoses related to dizziness and vertigo require us just to consider for a moment how the peripheral vestibular system works and what are potential areas centrally that could be involved if there is ischemia or infarct. So dizziness and vertigo pathologies fall into 3 major categories. The first are systemic causes. Is there hypovolemia, electrolyte abnormality, low hemoglobin, low glucose, low blood pressure? These are systemic causes. Is it peripheral? And by peripheral, we mean specifically abnormal vestibular function in either ear. And then lastly, we consider whether centrally there is central ischemia, an event such as an infarction, and or some lesion that is causing the vertigo to occur. So what is the normal vestibular anatomy and mechanisms? And what are the at-risk posterior circulation areas to which we refer? I again go back to our EB Medicine monograph by Jonathan Edlow, published in 2019. On page 4 of the monograph in Figure 2, the vestibular organs are identified. The utricle and saccule sense vertical and horizontal acceleration, change in speed. The 3 semicircular canals sense movements in the 3 different directions. And then lastly, the vestibular nerve carries the input to the brain from the periphery so that our brain knows how to guide our eyes so that our eyes stay in reasonable alignment even if our head is moving in a direction or accelerating in a direction. Now, what about posterior circulation ischemia or stroke? So the posterior circle of Willis blood flow, if disrupted, can cause problems in many areas of the brain. This is an excellent picture that identifies areas that are at risk. So if there is posterior cerebral blood flow disruption in the vertebral basilar system, you can have diminished blood flow and changes in cortical function, including the medial temporal and parietal lobes, here in blue. In purple, there could be disruption in blood supply to the thalamus. In green, the occipital lobes can receive diminished blood flow if there's posterior circulation problems. In orange, the brainstem, including the midbrain, pons, and medulla, may have diminished blood flow if there's vertebral basilar ischemia. And lastly, the cerebellum in pink can also receive diminished blood flow with vertebral basilar insufficiency. When considering the care of emergency department patients who present with dizziness and vertigo, it's important to consider some case studies to frame our further discussion of how we are to examine these patients and provide appropriate disposition. So the first is a dizziness case, a lightheaded 70-year-old. This 70-year-old female presents with lightheadedness for 5 days, and she states it's worse when she gets out of bed quickly in the morning. She says the dizziness sometimes will wake her up out of her sleep. She has hypertension. She's on cholesterol meds. Her vitals are found to be okay. She has a normal neurological exam. She has no nystagmus and is not found to be orthostatic. The question is, should a CT be ordered, and if so, why? Our second case is a syncopal 58-year-old male. Diabetic, he had some nausea and vomiting, ×3. Syncope reported, but he said he had such bad vertigo he had to lower himself to the ground. It began 3 hours previously and suddenly. He has some fast component nystagmus to the right, especially with gaze to the right. His HIT test is positive. His skew is negative. He's mildly unsteady, but he has relatively okay gait. The question is, based on this, do you call the stroke team? Our third case is a 44-year-old male with dizziness, and it's brought to you at the time of sign out, and one provider says to you, hey, can you just check the CT? This is a 44-year-old male, history of hypertension and diabetes. He has 6 hours of continuous dizziness. He appears to be unsteady. He says, I just feel like I'm drunk. He has normal vital signs, but he has left beating fast nystagmus with gaze. He seems to be improved following treatment with benzodiazepines in the emergency department. And of course, the famous sign out, if the CT is okay, can you just send the patient home with some meclizine? If we believe there's true motion symptoms that are consistent with the consensus definition of vertigo, we then need to consider specifically the central and peripheral diagnoses related to the 3 vertigo types we referred to earlier. We again go to the EB Medicine Timing and Triggers approach by Dr. Edlow for more information. And we go back to Table 1 and now consider in more detail the diagnoses to which we referred earlier. So again, there are 3 types of vertigo in green. There are benign diagnoses in yellow, 6 to be exact. And then there are 4 more serious diagnoses in red that correspond to these 3 diagnoses. Again, let's consider these 3 vertigo types. Is it continuous vertigo and the patient has the vertigo at the time of presentation? If it's continuous and current, that is defined as acute vestibular syndrome, and that is a diagnosis that can be made regardless of the patient's disposition. But if it is not current and continuous, and it's episodic in nature, those diagnoses are either spontaneous episodic vertigo or triggered episodic vertigo. So let's now refer to the attest system that was developed by Dr. Edlow to have a better understanding of those three types of vertigo. What does attest stand for? Associated symptoms that we will determine during our history, the timing of the vertigo, the trigger of the vertigo, the examination signs, and some confirmatory testing that needs to be done. So this is the clinical pathway defined as a test. And you can see it flows through based on specific questions, and we will now go through those questions so you can better understand this clinical pathway. Bear in mind there is some class of evidence definitions that supports these portions of the decision tree of the clinical pathway. So class 1 is obviously supported by the best data. Class 2, less support, but still important to consider in virtually all cases. And then Class 3 would be the weakest support from case studies, etc. And at times there may be indeterminate levels of clinical support. So what is the first part of the attest clinical pathway? It interrogates the general medical cause of the dizzy vertigo symptoms. On this clinical pathway, in the box in red, the first question is, does the history and physical suggest a general medical cause? Low volume, low hemoglobin, low glucose, low blood pressure. If the answer is yes, then you can go ahead and treat that etiology because it is important that a general medical cause such as hypovolemia be treated before we attribute the symptoms of the dizzy or vertiginous patient to some central or peripheral etiology. If the answer to the question, is there a specific general medical cause, if the answer is no, or if there's some attribute of their exam that is worrisome, such as worrisome nystagmus, you then go on to a different portion of the attest clinical pathway. Ask the first question, general medical cause. If yes, treat it, and then you can proceed to re-examine the patient after you've resolved that general medical cause. So, is there a likely medical cause? If the answer is yes, and if there's no worrisome signs, you say that's correct. No worrisome nystagmus, the patient can sit and stand. No motor abnormalities, no arm dysmetria, they use their arm well. No vision, speech, swallow, or sensory changes. Then you can treat the medical cause, and a CT generally does not have to be done unless there's something about the patient that causes concern. So what's part 2 of the attest protocol? Part 2 of the attest protocol or clinical pathway asks the simple question, has the dizziness been continuously present and does it persist at the time of the evaluation? If the answer is yes, it's continuous and it's present at the time of evaluation, you then can make the diagnosis of acute vestibular syndrome. Then the question becomes, what might be the cause? But we'll get to that in a bit. So you can see if you ask the question, continuous and present at the time of evaluation, the answer is yes. There's good evidence to support your ability to diagnose acute vestibular syndrome, and we'll talk more about that. If there's no likely medical cause, and or there's some possible worrisome nystagmus finding, for example, and if there's continuous and present vertigo, your diagnosis is acute vestibular syndrome. Now, if you diagnose acute vestibular syndrome, continuous vertigo, present at the time of evaluation, no apparent systemic cause, and you say, I think this patient has acute vestibular syndrome, you can then say it's either a peripheral etiology such as vestibular neuritis or neuronitis or labyrinthitis, which will involve some hearing loss. The alternate posterior circulation diagnosis would be an acute posterior circulation stroke, which of course is a clinical neurological emergency. What is part 3 of the attest protocol. If the patient does not have continuous vertigo present at the time of evaluation, the vertigo then is assumed to be intermittent. And that intermittent episodic vertigo can either be spontaneous or triggered. So let's consider first spontaneous episodic vestibular syndrome. That is, it occurs episodically or intermittently, and it appears to be spontaneous in its onset. We now move down to part 3 of the attest protocol, where the question becomes, is this intermittent dizziness or vertigo triggerable? In other words, is some movement or some activity the cause of the dizziness? And if the answer is no, if you say no, it doesn't appear to be triggerable, it just occurs spontaneously for no apparent reason, then you go on to the diagnosis of spontaneous episodic vestibular syndrome. So you say there's no likely medical etiology, but perhaps there's some worrisome nystagmus. And you say, okay, there's no continuous vertigo that's present at the time of my evaluation. And you say, is it triggered by standing up or head movement? If the answer is no, then you say, okay, it's spontaneous episodic vestibular syndrome, a peripheral etiology that is more benign than a central etiology for spontaneous episodic vestibular syndrome is Meniere's disease or vestibular migraine, here in green. More serious causes either are a cardiac dysrhythmia, which is not neurological per se, or the important posterior circulation diagnosis of a posterior circulation TIA. So, spontaneous episodic vestibular syndrome, spontaneous episodic peripheral Meniere's disease or vestibular migraine. Central or more serious would be a cardiac dysrhythmia or a posterior circulation TIA. We're still in attest part 3, where we talk about episodic vertigo and ask whether it's spontaneous or triggered. So now we're going to talk about triggered episodic vestibular syndrome. So we go back to our question, if the patient does not have constant dizziness present at the time of evaluation, and it appears to be episodic or intermittent, then the question is the dizziness triggerable by some activity, such as head movement? If the answer is yes, then we go on to consider the diagnoses related to triggerable episodic vestibular syndrome. So if triggered and episodic, you've said, look, there's no clear medical cause, something appears to be not right, but they don't have continuous or vertigo present at the time of evaluation, and the patient says it appears to be triggered with head movement. If that's the case, the peripheral etiology, which is more benign, would be BPPV, which is positional vertigo based on some triggered event such as head movement to one side. The more serious etiologies would either be significant systemic orthostatic hypotension, meaning you need to check orthostatics, or perhaps at times patient will have some posterior fossa lesion or tumor, which is a more central cause, which can on occasion cause triggered episodic vestibular syndrome. So you can see from determining the timing and triggers of the vertigo and determining what 3 types of vertigo or which of 3 it might be, you can then go on to what are reasonable assessments for possible likely peripheral or central etiologies. So now that we've discussed what are the possible peripheral and central etiologies to the patient with dizziness or vertigo, let's now consider the bedside physical exam. Again, we refer to the timing and triggers approach, monograph by EB Medicine, written by Jonathan Edlow, an emergency physician who has a specific interest in dizziness. If you look then at the clinical pathway for evaluating patients with dizziness and/or vertigo, there are 5 findings on physical exam that need to be considered for all patients in whom a central etiology is possible related to their dizziness or vertigo. Because patients with acute vestibular syndrome could have a posterior circulation stroke, and because patients with spontaneous episodic vestibular syndrome can have a posterior circulation TIA, it is essential that for all patients with either continuous vertigo presenting at the time of evaluation or for those with episodic vertigo, that we perform 5 physical exam tests specifically to evaluate possible central causes. Now bear in mind, a general physical exam needs to determine whether or not the patient is a vasculopath, whether they have adequate pulses, whether or not they have a cardiac dysrhythmia, whether or not they have an abdominal aortic aneurysm, for example. But once you've done this general physical exam, we are now going to focus on the exam related to the patient specifically with dizziness and vertigo. Now, the first thing you need to do is to examine for nystagmus. Why? Because the head impulse test, which we'll be talking about, is really most useful only in patients who present with some type of nystagmus. So the first thing we'll do is to check for nystagmus, trying to note where the fast component is. Then we're going to do a head impulse test, and we'll talk about that. Then we're going to check for vertical skew deviation. Then we will check for stroke exam findings, including new hearing loss, which can be assessed by rubbing the fingers by the ear to determine whether each ear has hearing that is adequate. And lastly, we'll check for ataxia, whether that's truncal ataxia and or ataxic gait or cerebellar ataxia. So if any of these 5 findings suggest a central etiology, then a posterior circulation stroke or ischemia are possible and or likely. And we're going to talk more about these specifically in a moment. So what are the findings that would suggest a central etiology to profound vertigo, either spontaneous and intermittent or patients with constant dizziness present at the time of evaluation, acute vestibular syndrome? What are those things that would make you consider a central etiology? The first, central pattern nystagmus. That is nystagmus that is not just related to a peripheral vestibular system malfunction. The second would be negative or no corrective saccade on head impulse test, and we will talk about that. If there's some skew deviation vertically, it means the pupils are not aligned adequately on the horizontal axis. That would suggest a central etiology. If there are any findings on neurological exam, including hearing loss, that would suggest a central etiology. And lastly, if the patient's unable to sit in the cart without veering to the side or cannot walk unassisted, that also would suggest a central etiology, a possible posterior circulation disruption, vertebral basilar insufficiency. Those patients need to be red lighted, considered for admission and further evaluation. So in Table 2 from the monograph, the 5 physical exam findings are listed here. In green are those findings that would suggest a peripheral etiology, and then in red are those findings that would suggest a central etiology. I would recommend you take a look at this monograph. It's a good example of what EB medicine does. Dr. Edlow specifically lays out much of what we're discussing in the tables and the text of this monograph. So now let's talk specifically about how we examine the patient with vertigo and try to establish a peripheral versus central etiology. The first thing we're going to do is to consider nystagmus, and I will refer most to those patients who present with acute vestibular syndrome, those patients who present to the emergency department with continuous dizziness that is present at the time of evaluation. How do we assess nystagmus in these patients? First off, as I mentioned, nystagmus is related to patients with acute vestibular syndrome. In other words, this is the most reliable time where you can determine whether nystagmus is central or peripheral, especially relating to a central cause related to posterior circulation disruption. The nystagmus exam in patients in other clinical settings will vary, such that these central versus peripheral tenets may not apply. In other words, what I'm about to discuss regarding nystagmus is important to be considered most in acute vestibular syndrome patients. The second, nystagmus is discussed first in our HINTS exam because the horizontal impulse test results only apply to those patients who are demonstrated to have nystagmus that could be related to a peripheral etiology. The third point or caveat prior to going on to discussing nystagmus is the following. If a patient presents profoundly dizzy, they have vertigo, they say they cannot stand, they cannot open their eyes because they have such profound vertigo with motion symptoms. If this patient does not have any nystagmus in the setting of profound vertigo and ataxia, a central etiology should be suspected regardless of any other parts of the HINTS exam. Why is that? If you are going to say a patient who is profoundly vertiginous has a peripheral etiology, they need to have some nystagmus in order to suggest that their abnormal eye movements is related to disruption in one or the other vestibular system. If there's no vertigo whatsoever, it is likely a central etiology to the vertigo symptoms. So now let's consider nystagmus in acute vestibular syndrome and whether it's peripheral versus central. In green, peripheral etiology, we know that with a peripheral etiology to acute vestibular syndrome, patients will commonly have horizontal nystagmus, and that's okay. That's expected if one of the vestibular systems does not keep the eyes aligned with head movement, for example. What type of nystagmus is common and okay in a patient with a peripheral etiology? The fast movement needs to be only in one direction. In other words, nystagmus related to a peripheral etiology, the nystagmus, the fast component that corrects, is only in one direction on the horizontal plane. So what, therefore, are the findings of nystagmus that suggest a central etiology? Number one, as we discussed, if there is profound vertigo and the patient has no nystagmus whatsoever, no horizontal nystagmus whatsoever, you should consider a central etiology, because if one of the vestibular systems is malfunctioning, it should cause some component of horizontal nystagmus to be observed. Other findings consistent with the central etiology include vertigo, Okay, so I'll start 3, 2, 1 with other. Other findings regarding nystagmus that are consistent with the central etiology include the following. Vertical nystagmus. Nystagmus vertically is not normal, is not to be considered a normal finding in acute vestibular patients who present with vertigo. Torsional or rotational nystagmus, which sometimes we observe in patients who take PCP, for example, is another example of central etiology in nystagmus. Also, if the fast component is bidirectional, that is to say, fast correction to the left, fast correction to the right, bidirectional horizontal fast nystagmus movement should be considered to be a central etiology. Why? Because it's not likely that both vestibular systems are going to malfunction at the same time. So if you have fast correction to the left and to the right, consider a central etiology. This is a pictorial representation from the monograph we've discussed. So, in summary, central etiology, no horizontal nystagmus whatsoever, or vertical or torsional rotational nystagmus, or horizontal fast component correction in both directions. And this is an example in red in the picture of fast component correction in both directions that would suggest a central etiology. So, central etiologies for nystagmus, no nystagmus whatsoever, vertical or torsional rotatory nystagmus, or bidirectional fast component nystagmus. Peripheral unidirectional horizontal fast nystagmus, suggesting that one vestibular system is sick. Now that we've discussed nystagmus in acute vestibular syndrome patients, if there is horizontal nystagmus and you're trying to determine with some degree of certainty that the horizontal unidirectional nystagmus is due to a peripheral etiology, we then move on to the head impulse test. Again, this test is most useful in patients with nystagmus. If the patient has no nystagmus whatsoever, consider a central etiology. What we're looking for on the head impulse test is an asymmetry in the vestibular response. So what is done is with the patient who has vertigo with acute vestibular syndrome in the emergency department, you move the head 15 degrees to the side and then quickly move the head to the center. If there is a peripheral etiology to the nystagmus and to the acute vestibular syndrome, if there is a peripheral etiology, one of the sides should have some component of Dahl's eyes on this acute oculovestibular reflex, and there should be some corrective saccade. In other words, on one of the two sides, with movement to the center rapidly, the eyes should lag a bit and there should be some correction to the center because one of the two vestibular systems is malfunctioning. If, however, there is no correcting saccade on either side, that means both vestibular systems are working correctly. If you don't see a correcting saccade on either side, then it's not likely that there's a peripheral vestibular problem, and therefore the vertigo could be central in etiology. If we go to figure 5, page 12 of the monograph, it shows how the eyes follow rotation to the disease side with the correcting saccade to the center. In other words, if there is a peripheral etiology, with movement of the head to one side, the eyes will tend to lag, go with it, and when movement back to the center, the eyes won't come back as quickly and they'll need to come back on their own. This correcting saccade is evidence of a peripheral etiology. If there's no compensatory saccade on either side, then the vestibular systems are working normally, and think a central etiology. So on this head impulse test, a central etiology again is suggested when there is no unilateral saccade observed on either side, suggesting no dysfunction in either vestibular system. So from the timing and trigger monograph, we come then to the language that discusses the head impulse test. Again, it's performed in patients with acute vestibular syndrome, continuous, present at the time of evaluation, with some component of nystagmus. Centrally, If there's no saccade in either direction, that's worrisome. It's not correct. It means that there's likely a central etiology because there's no vestibular dysfunction. If you do see a unilateral eye saccade, which is a correction to the center, this is actually good because a unilateral saccade suggests that one of the two vestibular systems peripherally is malfunctioning. So we conclude the head impulse test. Again, centrally, no saccade in either side or either direction of head movement means there is normal vestibular function bilaterally. If the eyes stay midline when you move the head back quickly, if there's no correcting saccade, that means the vestibular systems are working correctly and a peripheral etiology cannot be determined, and then you must think central. The only way to say there's a likely peripheral etiology in a patient with acute vestibular syndrome on head impulse test is that with rapid movement back, there's a correcting saccade on either the left or the right, meaning that one of the two vestibular systems is malfunctioning. Now that we've discussed nystagmus and the head impulse test, we will talk now about the test of skew in order to determine whether or not there's a peripheral or central etiology to the cause of the dizziness and vertigo. So the test of skew. The skew test is determined by keeping one eye covered, but then intermittently covering and uncovering one eye. If it is a peripheral etiology, there will be no vertical skew deviation to get the pupils lined up on the horizontal axis. In other words, when covering and uncovering the eye, there will never be a vertical movement to make the two pupils line up on a horizontal line. If there's any skew deviation, and that with covering or uncovering you see one of the eyes moving to correct, if that vertical movement is noted in either eye, when one or the other eye is uncovered, that would suggest on test of skew a central etiology. This is somewhat similar to having vertical nystagmus, where the eyes, the pupils tend to drift off on the vertical axis. So this test of skew, where there's correction on the vertical line, is a bad finding in acute vestibular syndrome patients. So a positive central test of skew would be some movement on the vertical axis to get the pupils to line up when covering and uncovering each eye. It's circled in red here from the monograph. So in conclusion, test of skew, a central etiology are where the pupils are misaligned vertically, and when you cover or uncover an eye, the pupils will move in a vertical line to get there to be alignment horizontally. A peripheral etiology can be assumed if there is no need for the pupils to line up or no vertical movement so that the eyes align on the horizontal axis. So now we've talked about nystagmus, head impulse, and tests of skew. Now let's just talk about the neurological exam and how it helps us to determine the difference between central and peripheral vertigo. A neurological exam that has no specific findings then supports a peripheral etiology. If there's no cranial nerve, brainstem, or cerebellar findings, you then can say it's likely a peripheral etiology. So what are some central findings? Limb ataxia, that is abnormal movement, heel to shin in the lower extremities, or finger to nose in the upper extremities, or the dysmetria that doesn't allow you to rapidly turn over your palms in either upper extremity. So the inability to move the limbs appropriately would suggest a central etiology. Dysarthria, the inability to move the mouth correctly, suggests a central etiology. I have here on the slide hearing loss in red because the HINTS Plus exam, HINTS Plus, The plus was assigned by Dr. Newman-Tokar, and it refers to hearing loss as an additional finding that adds to the ability of the exam to determine a likely central etiology. Also, when checking on the neurological exam for a central etiology, pain and temperature sensory loss must be determined. I put a few asterisks here because most people check for light touch, but actually if you're trying to determine posterior circulation, TIA or stroke related to vertebral basilar insufficiency, you do need to check for pain and temperature sensory loss, not just light touch. Lastly, some other findings that would suggest a central etiology to vertigo would be diplopia, any component of double vision, any ptosis that could involve a third nerve compression, anisocoria, which is a difference in pupil size, and or dim vision, which could be related to posterior circulation insufficiency. So, on neurological exam, central findings include ptosis, unequal pupils, hearing loss, brainstem findings, pain and temperature sensory loss, dim vision or dysarthria. Cerebellar would be limb ataxia findings. Peripheral would be no abnormalities either in the cranial nerves, brainstem or cerebellum. Lastly, when considering a patient who presents to the emergency department with vertigo, consider peripheral or central findings such as truncal ataxia and ataxic gait, which would suggest a central etiology. So a peripheral exam or a peripheral etiology that could be assumed for the vertigo requires that there be no findings when checking for truncal ataxia or ataxic gait. Central etiology should be suspected if the patient's unable to sit without holding on or leaning in the cart, or if the patient is unable to walk unassisted. In other words, they have truncal ataxia or ataxic gait. So again, to summarize, central findings, truncal ataxia, leaning when sitting, ataxic wide base gait when standing or walking. If those are not found, then a peripheral etiology might be the cause of the patient's acute vestibular syndrome and vertigo. So we've gone through the 5 exam findings that are required in patients who present with profound vertigo, the acute vestibular syndrome. And we'll talk now about the negative big 5 on the HINTS Plus and the plus exam, which I've added. So, on the HINTS Plus exam, which is head impulse, nystagmus, test of skew, plus hearing loss, I've added an additional plus in parentheses just to cover truncal ataxia or ataxic gait. What would suggest a central etiology in a patient with vertigo and acute vestibular syndrome? Number 1, vertical, torsional, or bilateral fast component nystagmus. Number 2, a normal head impulse test bilaterally, meaning there's no corrective saccade on either side, meaning neither vestibular system is ill and malfunctioning. If there's vertical skew correction to get the pupils to line up horizontally, that would suggest a central etiology. Then central neurological findings, limb ataxia, dysarthria, hearing loss, which is the plus in the HINTS Plus exam, pain or temperature sensory loss, diplopia, ptosis, anisocoria, dim vision. And then I've added in parentheses truncal ataxia or ataxic gait, because those are also relevant to posterior circulation ischemia or infarct. And I also add any findings that are related to anterior circulation stroke, such as unilateral extremity weakness, facial asymmetry, aphasia, or altered mental status. So, to reiterate, what are those findings that red light a patient's exam suggesting a central etiology? Bilateral fast component, vertical or rotational nystagmus. a head impulse test with no correcting saccade on either side, a test of skew that has some vertical component correction to get the pupils to line up on the horizontal axis, hearing loss, truncal ataxia or ataxic gait, and or anterior stroke signs. If any of these are observed, you know then the patient needs to be red lighted, considered for a central etiology to the vertigo and acute vestibular syndrome, and admitted for further testing. Alternately, what are the big five that will allow you to exclude a central etiology and then say it is a likely peripheral etiology to the acute vestibular syndrome and vertigo? So, in order to clear the patient and to get a green light to go, you need to have the following. In a patient with unilateral horizontal nystagmus that is unidirectional, that is, the fast component is only in one direction, not both, you then have to have one side that has a corrective saccade that would suggest that one or the other vestibular syndrome or system is malfunctioning because it is ill unilaterally. You also need to have the pupils aligned, no vertical skew. You need to have no posterior neurological symptoms, no hearing loss. The patient needs to be able to sit, stand up, or walk. And then you need to have no anterior stroke signs, no weakness, no unilateral face findings, no speech abnormality, no altered mental status. In other words, this is the HINTS plus exam listed at the bottom of the slide. The most important thing that I think you can learn today from all of this information regarding dizziness is circled here in red. In order for you to say it's a peripheral vestibular problem, one side needs to have a correcting saccade, meaning that one or the other vestibular systems in the ear is malfunctioning. On this slide, again, we reiterate what are the positive findings that would suggest a central etiology to the vertigo and acute vestibular syndrome. And one of the most important would be on head impulse that there's no corrective saccade on either side. So in other words, in order to make the diagnosis of vestibular neuritis in a patient with vertigo and acute vestibular syndrome, you need to have the following. You need to have unilateral fast nystagmus in one direction that suggests one of the vestibular systems is malfunctioning. You then need to have a unilateral saccade on head impulse test, where if you move the head, there's a correcting saccade on one or the other side in order to prove that one of the vestibular systems is malfunctioning. Remember, if there's no nystagmus whatsoever in a patient with acute vestibular syndrome, you need to assume a central etiology. And if there's no unilateral saccade on either side, you need to assume it's a central etiology. I wanted to go to just a few articles from our FERNE National Journal Club that address some of these questions related to dizziness and vertigo, the HINTS testing, and the medical literature. In one paper, the HINTS exam was compared to the ABCD squared test in order to determine stroke and TIA. And what we know is, if you do the HINTS exam plus an assessment for no new hearing loss, this gives us the highest area under the curve for diagnostic accuracy. In other words, if you see here in red the area under the curve, the yellow highlighted portion suggests that the area under the curve is almost 100%, meaning if you do the HINTS exam and check for unilateral hearing loss, you are going to have the best ability to detect and exclude stroke and TIA. From this paper also comes the Send Him On Home Safe Mnemonic. What does this mean? Straight eyes, no deafness, head impulse misses, meaning one side has a unilateral saccade. One-way nystagmus, horizontal, not bilateral fast component. Healthy otic and mastoid exam, stands alone, no ataxic gait, and face even, no paralysis unilateral on one side or the other. Another paper addresses the issue of nystagmus and posterior stroke. And the point of this paper is to say that nystagmus can't be used alone for the diagnosis of stroke. What do I mean by that? Nystagmus is often absent in central etiology vertigo. And we know that peripheral appearing nystagmus can be seen in central etiology vertigo. That's why you do the head impulse test and the test of skew. So knowing now that we need to do more than just the nystagmus exam, why is there so much emphasis on truncal ataxia and ataxic gait? Another study suggests that the HINTS Plus exam that includes a truncal ataxia exam is key. In other words, this study demonstrated that 15% of patients had no nystagmus but did have ataxia. In other words, you need to check for ataxia beyond the HINTS exam. So the HINTS exam must be supplemented by a neuro exam to search for truncal ataxia or ataxic gait. Now you might say, listen, the MRI is far more sensitive than any exam that I could do. If I think there's a central etiology, I'm just going to do an MRI. Now what's interesting is the HINTS exam, the physical exam that we've discussed extensively, may detect early stroke even before MRI DWI suggests any changes. In other words, HINTS is more sensitive than MRI DWI early after posterior stroke. Why is that? Because MR at less than 48 hours in a patient with acute vestibular syndrome could be falsely negative in up to 12% of patients. So, if the HINTS testing is 100% sensitive and the MRI is 88% sensitive, that means 12 out of every 100 patients will be missed on MRI that could be detected with your HINTS exam. In other words, about 1 out of 10 or 1 out of 8 patients you will detect on a HINTS exam even when the MRI is negative. Now what about machine learning? Can machine learning improve upon the HINTS test, looking at the components to determine whether it's central versus peripheral? Well, they actually do have machines that will detect changes on HINTS exam, and we can look and see whether the machine learning provides us any benefit. If you look at this graphical representation of the ability of different tests to detect a central etiology, the yellow line is the HINTS test. And the machine learning is in the purple box plot. And what you see from this is machine learning related to detection of HINTS findings using a machine that will video record the pupil findings. The machine had greater accuracy and area under the curve than the HINTS test alone. What about the patient outcome in our third patient who presented with dizziness and vertigo? Remember, it's a 44-year-old male, hypertension, diabetes, 6 hours of continuous dizziness. He felt like he was drunk, normal vitals. He had left beating rapid nystagmus, and his symptoms were improved with emergency department treatment, and the suggestion was if the CT is okay, he can go home with meclizine. Well, the CT was negative, but is the patient really clear to go? The patient had some decreased auditory acuity on the left, and when noted to be walking and standing, had some mild wide-based gait consistent with ataxia. The patient indeed was admitted. The initial MR DWI was negative. The subsequent MR at 72 hours was posterior for posterior stroke. And in fact, the patient in this example has right basilar occlusion and posterior stroke findings that are seen here on MRI related to this basilar thrombus. Here is a graphical or pictorial representation of places where you can have disruption in the vertebral basilar system leading into the circle of Willis. And I wanted to reiterate those areas that can be involved in vertebral basilar insufficiency or stroke, including portions of the temporal parietal lobe, the thalamus, the occipital lobes, the brainstem, and the cerebellum. No discussion of dizziness and/or vertigo is complete without discussing EMR documentation. So let's take a look at 3 different dot phrases that can be developed for use in any of the electronic medical records. The first would be a diagnosis of nonspecific dizziness. You would document no evidence of syncope or near syncope, no findings consistent with vertigo, no motion component, no physical exam or test findings detecting or demonstrating a systemic cause, normal cardiovascular exam, normal neurological exam, including HINTS testing, patient not orthostatic, normal vitals, EKG, lab testing normal, able to be discharged safely, patient aware and agrees with plan for outpatient follow-up, return as needed. The second dot phrase would be a dot phrase that is related to acute vestibular syndrome. This is a specific diagnosis, continuous dizziness present at the time of ED evaluation. You would say then patient has motion symptoms consistent with vertigo. They have a nonspecific neurological exam. Now, if they don't have a specific finding that would suggest a peripheral etiology, and what are those two? Those two would be either a unilateral horizontal nystagmus and a correcting saccade on head impulse tests suggesting one or the other vestibular systems is ill and malfunctioning. If those are not found and you have acute vestibular syndrome, you then need to admit the patient for further diagnostic testing because there remains diagnostic uncertainty. Our final dot phrase is related to patients in whom our HINTS++ exam actually demonstrates a peripheral etiology. In this case, your diagnosis is acute vestibular syndrome and likely acute vestibular neuritis. What do we document? From HINTS, we would say there's only horizontal nystagmus, there's no vertical, torsional, or bilateral or bidirectional fast horizontal nystagmus. The HINT test demonstrates a correcting saccade on the left, for example, consistent with left vestibular system dysfunction. There's no vertical skew correction, no facial or extremity weakness, no limb ataxia, dysarthria, speech abnormality or hearing loss, no pain or temperature sensory loss, no diplopia, ptosis, anisocoria, or dim vision, no truncal ataxia in the cart, no ataxic gait, and the patient's able to stand or walk without assistance. This dot phrase supports the diagnosis of a peripheral etiology such as acute vestibular neuritis. In this patient, you would say the patient is well, observed to leave the emergency department without assistance, able to be discharged safely, patient aware and agrees with plan for outpatient follow-up, return as needed, dizziness, vertigo medications provided as indicated. So, Is the vertical central? What is our general EMR documentation plan? Have a neurological exam template. Have a specific neurological exam for vertigo patients. Include a template that has hints plus, hints plus hearing loss, plus ataxic gait or truncal ataxia. Have dot phrases for decision making. Be able to document that the patient is functioning adequately, can walk out of the emergency department, and is able to walk, talk, see, stand. Have discharge instructions templated that would suggest what the patient needs to know in order to return to the emergency department, and know that your documentation will enhance patient outcomes because it allows you to know what you must document on history and physical in order to discharge the patient home safely. So let's summarize what we've learned from our dizziness and vertigo discussion today. What are our conclusions? We know that there are clear definitions that allow us to correctly diagnose vertigo and dizziness. We know that if you do the history backwards, that leaves dizziness as a diagnosis of exclusion. We know that syncope and systemic causes can be found for dizziness. We've learned that there are 3 vertigo types: acute vestibular syndrome and spontaneous EVS or triggered EVS. We know that with acute vestibular syndrome, we need to consider posterior stroke, and with spontaneous episodic or EVS, we know a TIA is to be considered. We know that triggered EVS, although often is related to BPPV, can be possible posterior lesion, suggesting possibly the need for CT. And we know we need to do a neuro exam plus the HINTS plus exams in all vertigo patients. We've learned that central signs on HINTS plus are easy to find and document. And we've learned that the HINTS plus is more sensitive than CT and MRI in patients with vertigo and acute vestibular syndrome. So our recommendations as a result of our discussion today: use a reverse history with dizziness, knowing that dizziness is a diagnosis of exclusion. Use your history, physical, vitals, labs, EKG, O2 sat to exclude systemic causes. Consider 3 vertigo types: AVS and then spontaneous or triggered EVS. With AVS, consider posterior stroke. With spontaneous EVS, consider TIA. With triggered EVS, think possible posterior lesion. If a patient has vertigo, do both a neuro exam and a HINTS plus exam. Template your central signs from your neuro HINTS plus exam. And given that the CT and MRI are less useful acutely, in any patient with vertigo and acute vestibular syndrome, use the HINTS plus exam to guide whether or not you believe it's a central etiology. And then be ready for new technology that will assist in central versus peripheral etiology assessments for our ED patients with AVS and vertigo. So, what are the red light findings in summary? On head impulse, no unilateral saccade observed on either side is bad. Nystagmus, bilateral fast component, is bad, as are vertical and rotational nystagmus. Any correction vertically on tests of skew is bad. Any hearing loss is bad. Truncal ataxia or ataxic gait are bad. And lastly, we know that anterior stroke signs are bad. If any of these are found, red light the patient and admit them for further diagnostic testing. So our final note on peripheral etiology must-haves in a patient with constant dizziness present at the time of evaluation, diagnosed with acute vestibular syndrome. In order to diagnose vestibular neuritis or labyrinthitis, saying that there's a peripheral etiology, saying that the patient is cleared, they're green lighted to go home with meds, you must have unilateral rapid component nystagmus horizontally only, and you must have one side that has a corrective saccade on head impulse, suggesting that one of the two vestibular sides is ill. The pupils need to be aligned vertically on skew. There need to be no posterior neuro signs or symptoms. The patient needs to be able to sit, stand up, and walk. You need to check for sensory pain and temperature, not just light touch. And there need to be no anterior stroke signs or symptoms, no unilateral facial weakness or extremity weakness, no speech abnormalities, no altered mental status. So some final take-home ideas related to the question, is the vertigo that a patient experiences with acute vestibular syndrome in the emergency department central in etiology? A few take-home ideas. Know the attest system and the three types of vertigo we discussed. AVS, or spontaneous and triggered EVS. Know the HINTS++ exam. HINTS plus checking for hearing loss plus checking for ataxia. Exclude anterior stroke signs and symptoms. Make sure the patient can walk, talk, see, hear, feel, swallow. Observe the patient walking out of the emergency department. Document using templates and give specific return symptoms in your discharge instructions so that if there is any worsening of the symptoms that would suggest an ongoing posterior circulation TIA or stroke, that the patient will return for further evaluation. So let's go back to our educational objectives. What do we know? We did go through our definitions both from the dictionary and from our consensus group. We know what diagnoses are related to the three types of vertigo. We know how to diagnose central causes. We know how to conduct our history and physical. We know about the attest system and the HINTS++ exam. We've reviewed a few relevant publications, and we're aware of new technologies that may assist us in detecting central etiologies for dizziness and vertigo in the future. And with that, I say thank you. For any further information, I encourage you to go to FERNE.org, or we can go to the FERNE.org channel and subscribe on YouTube, or you can send us an email at fern.org@gmail.com. Thank you for your time and attention to this important clinical information related to the neurological emergency of acute vestibular syndrome in emergency department patients. I'm Edward Sloan. Again, thank you and have a good day.